Okay, so starting with renal physiology, the first thing to talk about is the fluid compartments. So if we take, for example, a person whose weight is 70 kilos, um, 60% of that 70 of his total weight is only water. So basically, 60% of the whole weight of that person is water, and that is kind of equal to 42 liters. The other, of course, 40 is not water mass, just like muscles, cells, whatever, but not water. So out of that 60%, it will be broken into two parts. The first one is the major part, that is the 2/3. So 2/3 of that 60% water is actually just another water that is inside of the cell. So it's basically that 60% is going to be broken into two pieces. The 2/3 is 40%, and then the third part is 20%. So these combined would make the total 60% of water. So that 40% is this 2/3, and it's the major amount. It's the amount of fluid that is there intracellularly. So it's inside the cells, okay? While the least amount, that is the 1/3, that is the 20% of the total body weight, is the extracellular. So it is the water that exists outside the cell. So this is cell and it exists outside the cell. It's called interstitial fluid. So, the interstitial fluid by itself makes up to 10.5 kgs, and within that interest, of course, there's another part of the extracellular fluid that is not considered interstitium, that is the plasma, and it exists in blood. So the plasma of the blood makes 3.5 kilos, while the RBC volume makes 2.8 liters. So this is if we take a sample of blood. So basically we are taking an let's say a piece or a small amount of blood. Out of that amount, we will see that the majority of it is consists of plasma, and only a small amount of it is considered RBCs, and the RBCs, like accumulated, are called hematocrit. So the hematocrit that we have within a piece of blood is, or a small amount of blood, makes up 45 hematocrit. Like 45 of that blood is RBCs, red blood cells, while the rest of it, that is the 55% of blood, is only plasma. So if we read here, then we have this. There is, of course, high potassium intercellularly. When we get to that now, so the body is broken mainly into two parts, 60 and 40. So that 40 is not water, and that 60 is water, okay? So out of that 60, 40, as we said, is outside the cells, and 20%, or 20 out of that 60 is just um, um, uh, well, 40 was inside the cells, as I say, and then 20 was outside the cell. So, yeah, this is again the same thing that we're talking about. 60% is total body water, 40% is intra the cell, so intracellular fluid, and it's mainly composed. So, what's inside the cell over here? So, if this is the cell, so we can see potassium, magnesium, and then ATP, that is the organic phosphates, while the 20% that makes up the rest of the fluid that is outside the cells, it's mainly made of sodium chloride and HCO3, that is the bicarbonate. So the sodium is positive, chloride and HCO3, and albumin, of course, that's a protein. These are all negatively charged. The plasma volume can be measured by radiolabeling albumin. So if we are trying to estimate or know or measure how much plasma is there within the whole body, then we can add the radio labeling to the albumin, and the albumin is the protein that is there outside the cell. So it's extracellular a protein, and because it's extracellular, that means it's floating in the plasma. So if we radio label it, then we will be able to know how much is plasma is there in the body. So for the extracellular volume, it can be measured by inulin or mannitol. So that's for the extracellular volume, all of it, like containing um, plasma, of course. So plasma in its on all of its contents. And we will get to that later to understand why we are exactly using the aniline and mannitol or mannitol. So for a serum osmolality, well, it's measured, and normally it would be something between 275 and then 295. So that's normal, while the plasma volume is the total blood volume by 1 minus hematocrit. Okay, so these are equations to memorize. For the glomerular filtration barrier, this is responsible for filtration of plasma according to the size and charge selectivity. So because we know that we have the afferent arteriole coming over here and making this corpuscle of blood vessels, and then leaving as efferent arteriole over here, and we had the Bowman capsule surrounding it, then this Bowman capsule ending as the tubule. So over here, what is taking place is actually filtration, and the blood needs to be filtered, and that filtrate would pass through the renal tubules. So there are a few barriers that these filtrates or solutes or whatever going from the blood into the urine needs to encounter and face. So the filtration occurs, like what gets filtered apart from what does not get filtered is based on the size and the charge of the filtrate. So if like several substances or solutes has a certain size, then they will not be allowed to go into the urine. They will not be allowed to leave the blood. And some of those, depending on their charge, like are they positive or negative, will not also be able to leave the blood. So for the barrier itself, it's considered it's consisting mainly of three parts. One, two, three. The first one is the fenestrated capillary endothelium. So over here we have endothelium. That means this is a blood vessel. Okay, the pink thing is a blood vessel, and the wall of the blood vessel consists of these tiny cells. These are the endothelial cells, and the blood within this blood vessel can flow into the Bowman capsule through these fenestrations between the endothelial cells of the vessel. Then it will meet the next barrier. So this is barrier number one. These are the endothelial cells, and flows from between these endothelial cells, encountering the next part, the next barrier, that is the basement membrane, that has type 4 collagen chains and heparan sulfates. And then after encountering this second part, that is the basement membrane, they will meet the third barrier, and these are the green things over here, called the podocytes, and they consist part of the Bowman capsule, this purple thing that has to take blood from the glomerulus and move it into the lumen of the tubules. So of course the blood also moves from within the slits between each and podocyte and the other one next to it. So these podocytes are called visceral epithelial layer, consisting of podocyte food processes. So each one of those is considered a food process. Well, these are like the three main barriers that the blood has to move, like the filtrates that needs to go outside the blood into the urine have to face one by one, and the filtration through these barriers is based on either the charge or either the size. So if it's on the charge, for example, the glomerular filtration barrier contains negatively charged glycoproteins that prevents entry of negative charged molecules, just like albumin. So we know in physics that if the charge is similar on two molecules, they actually will go apart. So they don't like each other. But if the charge is positive, is different on these molecules, then they will like each other, they will move towards each other. So something to know for a fact is that the glomerular filtration rate, so it's this glomerulus, the barrier of it is negatively charged. So that's a fact that we need to know. So the blood contains albumin, for example. This albumin also has a negative charge, so it's unable to flow through that barrier. It will be not allowed to move. So the albumin will stay in the blood and won't be able to leave the blood into the urine because it has a negative charge. And as we said, the barrier also has a negative charge. So they don't like each other, they hate each other. So the albumin stays within the blood, not leaving into the urine. So that's barrier number one. So that's the first method of filtrating stuff. And the second method is the size barrier. So like few sizes are allowed and some few sizes are not allowed to go into the urine. So the fenestrated capillary endothelium prevents entry of more than 100 nanometers molecules per blood cell, while the podocytes for the processes interposed with the glomerular basement membrane, this diaphragm prevents entry of molecules of a size more than 40 to 50 nanometers. Well, these teeny tiny blood vessel cells that we talked about, they don't allow anything that is larger than 100, okay? So if we have a molecule that wants to pass from the blood into the urine, so it has to be questioned first how big it is. If it's more than 100 nanometers, then it will not be allowed. And then let's say if it's 70, then it will be fine to move. But then it will meet these green things, the podocytes, and it needs to move through the slits between each podocyte and the other. And now is going to be asked another question. Is it from 40 to 50, or is it more than that? So if it's 70, it was allowed first, but then here it will not be allowed anymore. It won't go into the urine because these slits between each podocyte and the other only allow molecules that are sized between 40 to 50 nanometers. That's it for the glomerular filtration rate. For the clearance, okay, so for the renal clearance, clear up all of this mess first. Okay, clear page. Great. So for the equation that we have here, the clearance of a substance, let's say this substance is called X, equals the urine concentration, like how much of that X is found in the urine, multiplied by, of course, it's multiplied by the urine flow rates, and then all of that is divided by how much of X is there within the plasma. So how much does the plasma contain of X? That equals for the clearance of that specific solute or whatever thing that we're talking about. That's called X. So this that means the clearance of X means the volume of a plasma from which the substance is completely cleared in the urine per unit time. So let's imagine there is some unknown volume of blood. So this is a volume of blood, okay? That contains a material or a solute that is called X, okay? It has a lot of X's. Of course, the normal progress is that this volume of blood will move into the kidneys and it will get filtered and excreted and reabsorbed and do all the stuff. And then it goes outside from the kidneys back into the blood. So it's the same amount of volume, but now it's completely free of the excess stuff, okay? It's completely empty of X. So it does not contain X at all. So this volume of blood is called clearance of X. So per unit time, this happens, the kidney clearance occurs during some specific time. So if the kidneys were able to clear that amount of blood completely from X, like they produce the same amount of blood without X at all, so that specific amount or that specific volume that we talked about is considered the clearance of that material that's called X. So basically, it's just the clearance is an actually is just a volume of the plasma, like of the blood, that this substance X was completely taken out in the kidneys during a unit time. So if we have here like a few options, if the clearance of that material, that X material, is less than the glomerular filtration rate, so the glomerular filtration rate for a specific person is known. I mean, we can measure it, we can know and determine how much is the GFR for that person. That is the normal glomerular filtration rate, normal amount of blood that gets filtered through the kidney, through each glomerulus of those. So if the clearance of that material is less than the normal GFR for that person, that means there is net tubular reabsorption and or it's not freely filtered. So that means after that material is being filtered through the glomerulus into the bone capsule, actually the tubule is reabsorbing more of it from the urine again, or it's not completely filtered. I mean, it's not completely cleared from the blood. That if we see that the clearance of the material X is less than the GFR. Well, if the material X is more, like the clearance of the material X is more than the GFR, that means there is net tubular secretion. More of that material is being added to the urine, okay? And then if the clearance of that material X equals the GFR, that means there is no secretion nor reabsorption. Like whatever getting filtered is just being filtered and gets out of the body without being reabsorbed or without being added to, and that's it. So for the glomerular filtration rate, we use the inulin clearance to measure it because it's freely filtered and neither reabsorbed or nor secreted. So let's imagine, so this is an efferent arteriole and it's doing all of this going back and forth. Okay, let me draw it there, okay? So it goes into the glomerulus, moving right there, and then going to the outside again. So this is afferent arteriole and this is efferent arteriole, and we have over here the glomerulus, the Bowman's capsule that surrounds the glomerulus, okay? So what normally should happen is that whenever blood comes into the glomerulus as the afferent arteriole, it contains let's say a material or X or inulin or whatever solutes that has, like let's say this unknown material, whatever that material is, it should normally, of course, be filtered into the Bowman's space, and then from the Bowman's space it moves forward into the renal tubule as urine, as filtrate. So this is filtrate and moving within the renal tubule until it gets excreted to the outside of the body as urine. So this, of course, is considered, the process is considered filtration. So in order to know how much does a person usually do the filtration process, or how much amount of materials actually gets out of the body into out of the blood into the urine, then we need to know the glomerular filtration rate for that person or for that kidney. In order to know that, we use the inulin. We use it specifically because let's say these blue things over here are actually pieces of inulin that exist in the blood. So they for inulin specifically, it's completely filtered. So all of these blue little dots in the blood will, all of them, move into the urine. All of them will get filtered. So now we don't have these, yeah. So now the blood is free of those, is free of those teeny tiny particles of inulin. And whenever they move in the renal tubule, they get excreted just peacefully and normally and fine. So there is no excretion of those anymore, and there is no reabsorption of those anymore, because we know if we take out of the urine into the body, this is called reabsorption. And if we secrete another amount, like an additional amount of a material into the urine, this is called secretion. So what happens with inulin, it's completely filtered. It's these blue arrows, and then it's neither reabsorbed nor secreted. So the whole amount just gets filtered and then moves peacefully as urine to the outside of the body. So that's why it tells us how much is actually getting filtered, and that's why we use it for the exact estimation of the GFR. So the clearance of inulin equals the GFR of that kidney, and well, because we're using the same equation over here, then it's the urinary concentration of inulin by the urine flow rate, all divided by the plasma concentration of inulin. So another way to draw this or write this equation is by using the pressure difference, or basically KF first is the filtration coefficient, and that is a specific fixed a number. And then let's take a look at it. Yeah, this is the image that is nice. Let's suppose there is a material, or like X or inulin or whatever, is going from the afferent arteriole into the glomerulus, and here in the glomerulus it gets filtered out. So there are a few pressures that are occurring over here. The particles within the blood in the glomerulus has two types of pressures: a pressure that pushes these particles to the outside of the vessel, that is called hydrostatic pressure of the vessel, and then there is another type of pressure that actually pulls things from the outside into the vessel. So this is called the oncotic pressure of the vessel. The same thing applies for the Bowman space. So this is the Bowman space. This yellow thing is the Bowman space. So it has two kinds of pressure on its own. So either it pushes its content to the outside, it just goes on and pushes everything to the outside. And also there's another type of pressure, but this is normally like it's there theoretically, but it's in functional people. The Bowman capsule doesn't have this hydrostatic pressure. But anyway, like any spaces, any fluids within the body has these two types of pressures. So the one that pushes things out, that's called the hydrostatic pressure of that place. And then there is the pressure that pulls things from the outside into the space, that's the oncotic pressure of the Bowman space. So now we have the vessel has two pressures. One is the hydrostatic pressure, and that is the pressure that pushes things to the outside of the vessel, outside the glomerulus. And also the glomerulus has the oncotic pressure that pulls things into the glomerulus. So take them from the outside into the glomerulus, into the vessel. And then the same thing applies for the Bowman space. It has the pressure that pushes things to the outside of the Bowman space. That is the hydrostatic and the pressure, and then there's the pressure that pulls things to the inside of the Bowman space. So for a normal individual, we have measured the GFR, and it looks like it's nearly 100 milliliters per minute. We said that the inulin has the exact amount of GFR, so we know it's an accurate estimation. While in clinical scenarios, in clinics or in hospitals, we don't measure inulin, we measure creatinine. Um, but it's not like the exact amount of GFR is just an approximate measure of the GFR, not just like inulin. Inulin and GFR are exactly the same, but for creatinine, it's just a slightly overestimates the GFR because why is it does it overestimate the GFR a little bit? Because this creatinine is being secreted into the urine. So it's not like inulin, neither reabsorbed nor secreted. Actually, this keratin is being secreted, so it's just a little bit overestimates the GFR. And for the graph that we have here, so this is a relationship between the glomerular filtration rate and then the plasma creatinine. So for the glomerular filtration rate, if a functional lung is normal, is not diseased, it's a healthy individual, healthy, wealthy person who has a very nice, functional, very good um, kidneys, then it will have a high GFR, like a normal GFR. And we said it was like 100. So let's say this is normal, 125 normal. So anyway, like something that is normal, that means that the kidneys are able to filtrate all of the creatinine, or at least like a very huge amount of creatinine. Creatinine is bad, okay? We need to get rid of it. So if the kidneys are functional and fine and not diseased and healthy, wealthy, then they will be able to filtrate the creatinine to the outside of the body. But if the kidneys gets a disease and their GFR just deteriorates and starts to, go down from the normal into the abnormal, that is 57, then it will deteriorate by time even more. It will become 50 and become 25. That's too bad. That's when the patient gets into renal failure. But that means that the diseased kidney is now has less GFR. So now it's deteriorating. Now it's unable of excreting the plasma creatinine to the outside in the urine. So that's why we see whenever, let's say at 60, specifically at 60, if the GFR gets really low into 60, we will see a lot of creatinine in the blood, and that is bad. That is wrong. That means that the kidneys are not functional. The kidneys are diseased. That's why we see there's a high concentration of plasma creatinine. So for the renal blood flow autoregulation, of course, regardless of the problems that happen or occur all over the body, the kidneys has their own way of um, trying to keep things safe. So they do have autoregulatory mechanisms. They help maintain a constant renal blood flow and GFR to protect the kidneys from rapid increase or decrease in renal perfusion pressures that could cause renal injury or decrease glomerular filtration rate. So of course, um, if the kidneys gets like only a small volume of blood, like they don't get the amount of blood that they need, then they of course will suffer and they will die. So what we have is autoregulatory mechanisms, is that the kidneys try to do their best on their own, just regulating how much blood they get, whether that patient is having heart failure or whatever the problem. It just tries to keep things safe and sound and fine. So the mechanisms are two: myogenic, related to the muscles, and the other one is tubular-glomerular. So for the myogenic, that means if the arterial pressure, like the afferent arteriole that goes into the glomerulus, like senses there is a high arterial pressure, then it will stretch. The afferent arteriole will stretch. It will feel that high pressure coming from the systemic circulation, coming from the aorta, coming into the renal artery, and then it will stretch. So that stretch will lead to the mechanical activation of vascular smooth muscles. Now the vascular smooth muscles will work. They are going to vasoconstrict the afferent arteriole because they sense there is a high blood pressure. They need to uh, um, lower it as much as they can, or they need to reduce the amount of blood that the kidneys are getting. So they do the vasoconstriction in order to get less renal blood flow and not care about what is happening in the body and not care about how much blood is coming. So they reduce the renal blood flow because they sensed it was high. So they don't really need the high, they just need reduced renal blood flow, and that's it. For the tubular glomerular, there is the tubular glomerular mechanism. It senses that there is an increased sodium chloride or tonicity of the filtrate. So a specific cells, macula densa cells, they are the cells that we talked about over here. Where are the macula densa cells? Ouch. The macula densa. Ouch. No, 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 no. No. Mine. Renal. There you go. This is the macula densa. So we said that it's part of the distal convolutubule, which means it will sense the amount of NaCl that is there within the distal convolutubule, like within the urine, I mean. So when it senses there is hypertonicity of that filtrate, or there's an increased amount of NaCl, then they will do their effect, and that is a paracrine-driven vasoconstriction of the afferent arteriole. So they do it through the paracrine process. So it's not endocrine. You know, the paracrine is when the cell excretes effects to different cells, but not within vessels, not going into the vessels, but it just affects the other cells surrounding it. So there is a paracrine-driven vasoconstriction, so decrease in the size of the vessels of the afferent arteriole, like the arteriole that is going into the glomerulus, and that's how they are reducing the renal blood flow. That's for renal blood flow autoregulation, and then for effective renal plasma flow, it's a small e at the start. That's how we know it's an effective renal plasma flow. It can be estimated using the para-aminohippuric acid clearance, because between filtration and secretion, there is nearly 100% excretion of all para-aminohippuric acid that enters the kidneys. Okay, so we know that, well, it's quite obvious over here. So these blue lines, blue arrows over here, these are the para-aminohippuric acid, and through the afferent arteriole is going into the glomerulus and then leaving the glomerulus. So as we can see that there is 20% of this para-aminohippuric acid is being filtered. So 20% of it is moving through the Bowman's capsule and everything and going into the urine. And then the rest of it, just because we know that the blood vessel, the efferent arteriole, like the one that goes out, the efferent, the efferent goes right next to the renal tubule, so it still contains the rest of the para-aminohippuric acid, and these are the blue arrows over here. But all of these, actually, the remaining 80% gets secreted into the urine. So that's it. Just 20% gets filtered, and then 80% gets secreted. That makes up the 100% of the para-aminohippuric acid, the 100% of the amount of it that came into the glomerulus doesn't actually go back into the blood. It just gets filtered, and then the remaining amount gets secreted into the urine, and that's we have a clear blood out of the para-aminohippuric acid. So that's why the equation that we're using here is the effective renal plasma flow. The same thing goes, but only for the para-aminohippuric acid, and that equals the clearance of the para-aminohippuric acid. Another equation for that is that the renal plasma flow divided by 1 minus hematocrit. A fact to know is that usually the kidneys get 20 to 25% of the cardiac output, of the whole cardiac output. That is due to their autoregulation, because they autoregulate the amount of blood that they need to go into the kidneys. So the effective renal plasma flow underestimates true renal plasma flow slightly. So this effective renal plasma flow that we measure through the para-aminohippuric acid just a little bit underestimates the renal plasma flow, which means the actual renal plasma flow in a normal individual is a little bit more than the number that we can get by measuring the effective renal plasma flow using the para-aminohippuric acid. And then we have the filtration. That's it.